My name is Matthew Koff. I'm an assistant professor of anesthesiology and critical care medicine at Dartmouth-Hitchcock Medical Center. This is an educational video about the esophageal Doppler monitor. What is the esophageal Doppler monitor? It's minimally invasive. It utilizes Doppler technology and directs a beam of ultrasound waves at red blood cells in the descending aorta. The esophageal Doppler utilizes two-dimensional waveform, velocity and time, representing blood flow in the descending aorta. This illustrates real-time changes in blood flow, providing indirect reflection of left ventricular function. What information does it give us? It can tell us about a patient's hemodynamic status, preload, afterload, and contractility. It gives us familiar values such as cardiac output, cardiac index, stroke volume, heart rate, systemic vascular resistance. And it also provides new values, the FTC, or flow time corrected, and PV, or peak velocity. The key to utilizing this monitor is that fluid management can be individualized to each patient utilizing the Starling curve to safely deliver intravenous fluids to optimize stroke volume. The esophageal Doppler utilizes a nomogram based on age, weight, and height to create a calibration constant, or K-factor, which is used to convert distance to volume. This is developed by comparing esophageal Doppler monitor stroke distance calculations against simultaneous stroke volume measurements by pulmonary artery catheter thermodilution. Stroke distance is the area under the curve. Stroke distance times the calibration constant equals a stroke volume, and this basic measured parameter upon which calculations of stroke volume and cardiac output and index measurements are made, remembering that cardiac output equals stroke volume times heart rate. Stroke volume equals the stroke distance times the cross-sectional area of the descending aorta. The cross-sectional area of the aorta is based on the nomogram of the age, weight, and height. The nomogram limits are ages 16 to 99 years, weight 30 to 150 kilos, or 66 to 330 pounds. Height is 149 centimeters to 212 centimeters, or 4 foot 8 inches to 6 foot 9 inches. When outside of the nomogram, you can make the patient fit the nomogram and follow trends, or you can utilize directly measured data. Stroke distance, which is the velocity time integral, which the area under the waveform. Stroke distance is linear to stroke volume. Minute distance is the distance of a column of blood as it moves through the descending aorta per minute. Minute distance is linear to cardiac output. About the esophageal Doppler probe. Contraindications to use of the probe is known pharyngoesophageal gastric pathology, malignancy or esophageal perforation, thoracic aneurysm, bleeding or coagulation disorders, aortic dissection, intra-aortic balloon pump, or patient in an MRI scanner. General information about the probe. The probe can be inserted either in an oral or nasal insertion. In adults greater than 16 years old, the microchip remembers patient data initially entered on the patient data screen. It's flexible, it's silicone, and it's latex-free. Inserting the probe, there are markers on the probe, and there are 2 markers for oral placement, usually inserted to 35 to 40 centimeters around the T5, T6 region. You should lubricate the probe prior to insertion, as this is important for transmission of ultrasound waveform and ease of insertion. The bevel on the probe should be angled up, so probe is positioned to the descending aorta. When inserting, ensure the bevel is facing the roof of the mouth. This will help position the angle of the probe to the posterior position where we will find the descending aortic blood flow. The probes have markers on them to help guide appropriate depth, and the first 2 markers should be used for oral placement. The second and third markers should be used for nasal placement, usually around 35 to 40 centimeters in depth, around T5 to T6. Advance the probe until blood flow signals are detected. If you meet resistance, do not force the probe. Optimizing the signal. Rotate the probe gently and adjust probe depth until characteristic descending aortic velocity waveforms are seen. As you focus the probe, you hope to see the descending aortic blood flow as noted in screen left. If the probe is focused incorrectly within the heart, you will see the example on screen upper left. If the ultrasound probe is too deep within the patient, you may see a venous signal as shown on screen right. If you have trouble obtaining a signal, you may need to rotate the probe using slower movements. You may need to take it out and re-lubricate. You can increase the gain on the monitor, or you may have to advance the probe further or pull out depending on patient height. If the patient already has an oro or nasogastric tube, you may need to remove this tube and place the esophageal Doppler first and then reinsert the nasogastric or orogastric tube. This allows the monitor probe to lay more posterior towards the descending aorta. The sound is the most important factor while positioning the ultrasound probe and focusing. You want to hear a high-pitched sound of blood flow leaving the descending aorta. The esophageal Doppler acquires signal, calculates the important variables based on cycle time, or the number of beats that are averaged. In this example, the cycle time is set at 5 beats. For atrial fibrillation, you may need to increase the cycle time. This can be adjusted in the parameters section. You should always start with the filter off, and you can turn on for severe interference. You may need to adjust the gain for the amount of ultrasound transmission. This is an example of the esophageal Doppler waveform. It's based on continuous wave Doppler shooting across the descending aorta. And what you see is velocity of blood flow in centimeters per second in the y-axis over time in milliseconds. This is an example of poor focus, and you will hear audio that indicates inadequate ultrasound focusing. If this is the case, you need to carefully focus the ultrasound probe and continually put your finger on the probe to focus. The numbers acquired during poor focus will be inaccurate. The flow time corrected is a novel parameter measured by the esophageal Doppler. The flow time corrected is the flow over time over the square root of the cardiac cycle. Cardiac cycle can be divided into systole and diastole, and systole is around 1/3 of the entire cardiac cycle. So the normal value for flow time corrected is between 330 and 360 milliseconds. A reduced blood volume would be represented by narrowing of the base, or flow time, and also a reduced area under the curve, such as stroke distance. The whole waveform will look narrower. A decreased flow time corrected, or a flow time corrected less than 330 milliseconds, can be indicative of vasoconstriction. The most common cause is hypovolemia. Other causes are hypothermia, vasopressors, or pulmonary embolus. Increased flow time corrected, or a flow time corrected greater than 360 milliseconds, can be indicative of vasodilation. Possible causes include sepsis, medications such as vasodilators or anesthetic agents, or fluid overload. A hypovolemic patient can be detected by the waveform shape and by a low flow time corrected. As the heart rate has less blood to pump, the waveform base becomes narrow, and the flow time corrected falls below 330 milliseconds. In comparison, on screen right, a normal volemic patient has a wider waveform base and a flow time corrected within the normal range of 330 to 360 milliseconds. Peak velocity is the blood flow at peak of systole. It's a marker of left ventricular contractility, and it can be useful for titration of inotropes. The normal range for peak velocity depends upon age, and it decreases linearly with age. This is an important chart that you need to reference, which describes normal peak velocity values. These are examples of changes in contractility as represented by the peak velocity. An example of a low peak velocity as represented in left ventricular failure on screen left is represented by a peak velocity of showing 46. With the addition of inotropes, an improvement in the peak velocity is shown on screen right, showing a peak velocity of 76 centimeters per second. The afterload affects the width and amplitude of the waveform. Monitor changes in afterload by looking at concurrent shifts in both flow time corrected and peak velocity. Increased afterload, you might see a decreased flow time corrected and peak velocity. Reduced afterload, you may see an increase in flow time corrected and peak velocity. Flow time corrected is inversely related to systemic vascular resistance. A high afterload state, you may see a low flow time corrected, and conversely, in a reduced afterload state, you may see a high flow time corrected. More information with regard to bibliography and groups that are endorsing the utilization of this technology for patients can be found on the Deltex Medical website as listed above. Specifically, the AHRQ, CMS reports, as well as the Enhanced Recovery and Fast Track Surgery websites.